All right, on this episode, we're going to do part one of ECG Fundamentals. I was going to try to make this all one video, but it just came out too long, so I'm going to break it into a couple different shorter videos, make it a little bit more digestible. And so I wanted to start with something I think is probably one of the most important foundational elements to ECG interpretation, which is just building an ECG map. And I think a lot of traditional ECG teachings kind of don't focus on this, and I get a lot of people asking where I learned kind of my methodology, and this is it. Is I took the time and I applied a conceptual understanding of where each of these leads look and what that means. And when I'm interpreting an EKG, it's painting me a picture, and I can apply that to the clinical presentation of the patient to improve my diagnosis. So I wanted to make sure that we were all on the same page on a couple key elements that I think have a huge implication on what I'm going to say moving forward. And so when we're talking about looking at ECG waveforms, irrespective of the lead for right now, and just understanding what it means when you have a big versus a small waveform, or a narrow versus a wide waveform, and then the direction. And when I say direction, I'm talking about is the waveform deflected up above the isoelectric line or below it. Each of those key elements are really, really important. They give a lot of information, and I think a lot of people kind of skip over or gloss over these things, and a lot of the really complex ECG interpretation that we do really just boils down to taking those little bits of data and then applying it to that ECG map, so knowing where these leads look, and then kind of painting a picture about what's going on in the heart. And so just so that we're all on the same page, when we're talking about height or the overall size of any waveform, whether it's the P wave, the QRS, the T wave, however big that waveform is, that indicates that the electrode or that lead was receiving more energy. So the bigger the waveform, the more energy. Now, that doesn't necessarily mean the heart is producing more energy. That's obviously probably the most common, or one of the most common ways that we would see that, right? A big heart is just going to produce more energy, and so the ECG is going to get bigger. The P wave might get bigger, the QRS might get bigger, if just part of the heart is bigger. So if I have big P waves, well, that very likely to be that I have atrial enlargement, since the P wave represents atrial depolarization. If I have big ventricles, well, I'm probably going to end up with bigger QRS complexes. Again, that's not always the case, because there's a lot of variables that affect how much energy the electrode receives. Of course, the heart producing more energy is key. That's why if you've ever noticed maybe some of your patients when they're in distress, maybe they're hypotensive, they're shocky, their endogenous catecholamine response is surging, you may have noticed that the QRS complexes get bigger, and then as they start to feel better, they start to go down. Well, that's just because the heart was more excited and it was beating more forcefully, perhaps. It was producing more electrical energy, and the ECG received that. But then also too, you may have noticed that if you've done a 12 lead on like a small child, you notice your QRS complexes are really big, even if the patient's not in distress, and that's counterintuitive. It should be smaller, right? The heart is smaller in the infant or toddler compared to an adult, so I would expect the waveforms to be smaller, but instead we often see the opposite. And why would that be? Well, the energy has a shorter distance to travel, since the chest wall is relatively thinner in ratio compared to, say, the adult patient, especially when you start adding on adipose tissue, breast tissue, COPD or some pathological conditions, morbid obesity, any of those things, those impede the signal. The electrical energy has to pass that medium, and it impedes the signal that the ECG receives, and so you get smaller QRS complexes. You see this with your limb leads versus your precordials. Often your precordials are bigger, all the waveforms look bigger, and that's not because of anything other than the electrodes that sit on the chest are just closer than your limb leads are. So height equals amount of energy, and that's going to be key when we talk about a few things coming up. Width, on the other hand, that the x-axis on the ECG is time, and so the wider something is, the longer it's taking to occur, and that can be things like some conduction delays, maybe the pathways are disrupted, maybe we have a bundle branch block, or some sort of a myocardial ischemic injury that's causing some sort of conduction delay or an electrolyte problem, or a multitude of issues. But it's indicative that whatever waveform you're looking at, if it's wide, if the interval is wider than what it is supposed to be, then that's telling you that that event is taking more time, whether that's ventricular depolarization, atrial depolarization, or repolarization. And then the last part, which is what I'm going to focus on the most, is the direction: up, versus down, because this is very key. And this is a fundamental element of ECG interpretation. Depolarization of a muscle cell is a positive change in the membrane voltage. And so if you have a depolarization wave that's moving through the heart and it's moving towards any particular lead, then that waveform will be reflected upright. It's moving away, then that waveform will be reflected down. And this is actually opposite in T waves, and I may need to do a separate video on this because it gets complex, but in short, you repolarize in reverse typically, which is why your QRS and T waves are often on the same side of the isoelectric line, even though they represent opposite polarities. But I really want to focus on the up and down, especially with the QRS complex, because that's telling me where the flow of electricity is going through the heart when it's firing, when it's depolarizing. And we can learn a lot by understanding where those leads look and where that energy is traveling. So this is my ECG map, and when I lecture, I actually have a three-dimensional model that I use that kind of puts this all together, but obviously doesn't correlate here. And so we're gonna have to use 2 dimensions to kind of articulate this. But what you're looking at here on the left are your limb leads, right? You put 4 electrodes on and you get 6 views, which, by the way, that's one of my pet peeves. It's not a 4 lead, it's either a 3 lead or a 6 lead. You're putting 4 cables on, 4 electrodes on, but you're getting 6 leads. So they're technically called hexaxial leads because you're getting 6 viewpoints. The key component here is that they look vertically at the heart. So to orient you to what you're looking at, when you look at the picture on the left, you can see the SA node at the top. The blue lines represent the conduction fibers. So you see the green SA node, the green AV node, and then your bundle branches. And so this is oriented up, down, right, left. So the patient's head would be at the top of the screen there, and the patient's feet would be at the bottom. There is no front and back on this view. It's just up, down, and right and left. And so your 6 leads, 1, 2, 3, and then your 3 augmented leads, augmented vector left, right, and foot, AVL, AVR, AVF, they all look at the heart at different angles and kind of give you almost a 360-degree vertical view of the heart. And so this can tell us a lot. And when we talk about things like cardiac access, these are the first leads that we're looking at here because they're going to tell us that flow of energy. And when we start talking about more complex topics, all of this is applicable. If there's anything I could beg you to take from this is don't skimp over this. Memorize this map and use it. There's so many things that matter. If you want to diagnose STEMIs, right? Well, if I have an inferior STEMI, right, that's the bottom of the heart, well, then you're going to have ST elevation in 3 in AVF, and then the least in 2. It's rare that you have 2 have the most ST elevation inferior. But you're not done, right? With a STEMI, you have to have that reciprocal change, which means the opposite. So if I have ST elevation in 3, I should have ST depression in the lead that looks the most opposite, and that's going to be AVL. And so that's important. I want to see ST elevation. Well, ideally, I guess, don't want to see ST elevation because that's bad. But if I see ST elevation in 3, then I'm looking at ST depression in AVL. And actually, as you get really good at ECG interpretation, you may have come across that if it's a true inferior STEMI, it is much more likely to have more ST depression and more reciprocal changes in AVL than in 1. And that's because AVL's viewpoint is more reciprocal to the infarction that's occurring at the bottom of the heart because it has a higher angle of view. And there's so many other things. If a patient has left ventricular hypertrophy, well, guess which leads are going to be the biggest and the most upright? They're going to be 1 in AVL. Why is that? Because they look at the left side of the heart, and that's where the energy is producing. If you have a left axis, your QRS complex is going to be the most positively deflected in AVL. Why? Because the energy is traveling in that direction. And again, I could go on and on. On the other side there, you can see your precordial leads. And so those are your chest leads. Now, to orient you here, the patient's head would actually be coming out of the screen at you. So at the top of that graph, at the top of that picture would be the patient's back, and at the bottom would be the patient's front, which makes sense. The V1 through V6, that's where we put the stickers, right? We put them on the chest, and we look. So they look directly backwards. And so they give you a different view. And so if you do a true 12 lead, you're really getting almost a 3-dimensional picture by looking at, looking at the vertical plane with your hexaxial leads and then looking at the horizontal plane with your precordials. There is no up and down in this case with your precordials. There's just front, back, and then right and left. And so the same concepts and the same things occur. When you learn this map and you start to understand those basic things, like what does it mean when a QRS complex is big and upright? What does that tell me? And so you can start to infer things and learn things, right? Good example. If V1 and if V1 through V4 are showing ST elevation, well, you can see that's the anterior part of the heart. So you're going to have maybe an anterior stemi. Or if, I could flip it. Maybe I have ST depression in V3 and V4. Well, they look at the front. If I have depression in the front, maybe that's reciprocal depression and I have ST elevation in the back. Too, if I have right ventricular changes, those are going to show up on the ECG with changes in leads V1 and V2 predominantly. Why? Because they look at the right side of the heart there. So one of the things I like to ask whenever I'm doing ECG lectures, especially to licensed providers who have a little bit of experience, is I ask them, what is normal? Because obviously our job is to identify abnormalities, and hard to do that if we don't know what normal is. And what I mean by that is, what is lead 2 supposed to look like? What's AVR supposed to look like? What's V1 supposed to look like? What's V supposed to look like? Because if you don't know that, you won't pick up on some of these abnormalities. And I see a lot of providers, they send an EKG to me, or they come into the hospital, or vice versa, and they're telling their interpretation is that it's a perfectly normal EKG, and then I see all these abnormalities on here, that some of which can be concerning and even life-threatening. And so this is very important to master this part here. And so when you look here at this chart, you can see I've got a norm on the left side. We've got half of an EKG, so it's the 6 hexaxial leads, and this is just kind of a normal progression. So there's a normal sinus rhythm with the electrical flow that's going in a normal direction. So when I map that out, lead ABF, lead 1, lead 3, a lot of those leads, they have some variance in what they're supposed to look like, but AVR and lead 2 especially, they have a pretty predictable pattern in a normal EKG. Everything is moving away from AVR. So from the point that the SA node fires, you get your P wave, your QRS, the T wave, everything is moving away from AVR's vantage point, so everything is reflected down. And lead 2's vantage point, since it's looking from the complete opposite view, everything's up. Your P wave is typically up, your QRS is up, and your T wave's up. Any deviation from that is abnormal. Doesn't mean the patient's dying, but it is an abnormality to have, say, a prominent R wave in AVR, or a prominent S wave in lead 2. Again, not necessarily lethal, but it is abnormal. And the same thing goes with our precordial leads. Well, you can see there on your ECG, I have just a normal presentation for your precordials. So from V1 to V6, that's just a normal progression. And then I've just mapped it out with our ECG map there. So because adult humans are left ventricular dominant organisms, from a horizontal plane, your depolarization wave moves from right to left, or it moves away from V1 and towards V6. Now, of course, the right ventricle depolarizes right towards V1, but you can kind of see there the cross section of muscle tissue. The right ventricle is very, very small in comparison. It's producing minimal electrical activity. And so all the EKG can show you is net electrical flow. So if I was really to map this out, I really should put a bunch of little tiny arrows kind of moving towards V1. That would be the right ventricle, but and then a bunch of big arrows kind of moving towards V6, and that's because the left ventricle fires from right to left, and it kind of dominates the EKG in an adult patient. And so normal V1 in an adult is completely down. The QRS should be down. The P wave should technically be biphasic, because from V1's vantage point, one of the atrium actually fires towards it and the other one away from it. But again, that's small amplitude and it's not always picked up. From V6's vantage point, everything should be up. The P wave, the QRS, the T wave. That's a normal progression. And then every lead in between is a progression from the QRS starting down and then transitioning to up. And so if you look back over the actual ECG, you can see this happen. So V1, you have almost no R wave being the upright waveform. It's just an S wave, it's just down. And then in V2, you're starting to see that R wave grow, V3, it's getting more prominent. And then in a normal EKG by V4, the QRS complex should be overall positive, meaning that the up part should be more than the down part, or what the fancy nerdy people say is an RS ratio greater than 1, which is just intellectual terrorism trying to make something sound really complicated when all they're trying to say is that the QRS is overall positive. So if you see anybody talking about RS ratio greater than 1, that's what they're trying to say. They're trying to impress you with their lovely brain knowledge, but they're being fancy for no reason. The QRS is up in V4. And if you look at the map, that makes sense, right? Because you can see V1, V2, V3, that depolarization wave is moving away, but by the time you get to V4, now it's starting to look towards it. And so it's going to be more up than down or overall positive. By V5, the S wave has shrunk considerably, and then by V6, it's almost completely gone, and everything is upright. That's a normal progression, and that progression of the R wave is called R wave progression. And if you've ever had a 12-lead printout, an interpretation, and it said something about poor R wave progression, and you were like, yeah, I should probably know what that means, but I don't. The machine was measuring the R wave in V4 and seeing if it was bigger than the S wave in V4. And if it wasn't, so if it was still negative in V4, then the interpretation is going to say poor R wave progression. What that means clinically is that the depolarization wave is actually moving towards the back of the heart. That can mean all kinds of things. Most are not lethal, but some are. If your anterior wall starts to die from an acute anterior STEMI, you will start to eventually lose the R wave in V4 because the R wave in V4 is produced by the anterior wall of the ventricle. And if it's dying, it may not be making energy anymore. And in fact, that will be a permanent change in anyone with an anterior STEMI. If it progresses long enough, the R wave can be permanently lost, and the patient will always show poor R wave progression on their ECG. Right, so let's do some practice here. We're going to map this out. We're going to map it out on the vertical plane, and we're going to map it out on the horizontal plane. So if we look here, let's start with the hexaxial lead. So 1, 2, 3, AVR, AVL, AVF. I'm kind of looking at my waveforms. I'm looking at up and down, and I notice that it's a little abnormal. Remember, lead 2, everything is supposed to be up, and instead the QRS is down. And when I look, AVL is the most upright QRS complex. And that's not what it's supposed to be, right? If we remember, AVL stands for augmented vector left. It looks over the left shoulder. And so that tells me that from a vertical standpoint, the ventricular depolarization wave is moving towards my left shoulder, which is a left axis deviation. So it's moving up and to the left. And I'll have a map in a second to show you. If we look over at the hexaxial leads, well, we got another problem because again, V1 is negative, that's normal, but V6 is supposed to be completely positive, and all of the leads on the far right side of the ECG, so V4, V5, V6 are all supposed to be upright and they're down. And that's telling me that the depolarization wave is being deflected to the back. So let's see a map to kind of correlate that here. So if I look, I have left and posterior deflection. If I've kind of mapped it out and compared, and I've overlaid the patient's ECG. So I cut the EKG and I placed it based on each lead's vantage point. So you can see here, because AVL has the most upright QRS complex and the QRS represents ventricular depolarization, that's telling me that it's moving up and to the left. And then you can see that lead 3 is down. Now, a lot of people use this little cheater thing for cardiac access. Again, I hate all of those things. Yes, it's accurate. Some people do the thumbs up, thumbs down thing. It drives me nuts. That's very accurate. It makes all it breeds is codependency, and it robs the provider of conceptualizing what you're trying to look at, which is what actually matters. It drives me nuts. I see people pull out like little cheat sheet cards they keep in their pocket. Like, that is useless. Just take 5 minutes and learn this. The whole, you can see the whole concept here. If I have my little cheat sheet, it's going to say, well, if the QRS is down in lead 2 and it's down in lead 3 and up in AVL, you have left axis. Well, guess what? If the QRS complex is the most positive in lead AVL compared to any of the other hexaxial leads, if it is the most positively deflected in AVL, you have a left axis. And it's going to be down in 2, it's going to be down in 3. That's redundant and already known. You don't need to do that. If the QRS complex is the most upright in AVR, then that means that the depolarization wave is moving completely backwards from where it's going. We call that extreme right axis deviation. If the QRS complex is the most upright in lead 3, then you have a right axis deviation. And by the way, that means you have a problem with the right ventricle, and that would correlate with things like pulmonary disease. Why pulmonary disease? Because the right ventricle pumps blood to the lungs. And so people with pulmonary disease will end up developing right ventricular hypertrophy as a result. If they have chronic end-stage COPD, perhaps that's a very common thing that can occur because they have high pulmonary pressures, and over time the right ventricle becomes hypertrophic, it produces more energy, and bam, you end up with a right axis. Do you have to have that on every one? Absolutely not, but it can happen. So here, AVL is most upright, and we have that QRS, that ventricular depolarization moving in that way. So we have a left axis deviation from the vertical plane. Let's look over at the horizontal. It's down in V1, but it's still down in V6. That tells me that it's being deflected to the back, or I have posterior deflection. So this is a very specific finding, and this is indicative of something called a left anterior fascicular block. And I've actually mapped that out and correlated it there. So you can see the left bundle is actually broken into two branches, the posterior and anterior fascicle. And sometimes you can just get a complete left bundle, but sometimes you can just get a partial left bundle. And so you can either have a left anterior fascicular block or a left posterior. Of the two, the left anterior fascicular block is markedly more common, and the left posterior is very rare. So you can see here from the vertical axis, the left posterior fascicle is responsible for sending energy up and to the left. And so if I blockade the anterior fascicle, I'm going to get a left axis deviation. And then from the horizontal plane, the left anterior fascicle is that black line you see there. It runs around to the front. That's where it gets its name. And then the left posterior fascicle runs around the back. And so from a horizontal plane, I am directing or deflecting depolarization to the back. And so your common presentation for a left anterior fascicular block is a pathological left axis with posterior deflection. Or if you can't memorize that map, then you can memorize the criteria, which is a QR wave in 1 in AVL with an RS wave in 2, 3 in AVF, with the QR wave being at the highest magnitude in lead AVL, and then having a RS ratio about less than 1 in V6, right? That's easy to remember and just rattle off really quick. Or you can just memorize this map and just kind of conceptualize it there. You have a left here, really simple. If I have an upright QRS complex in AVL and it's the most positive and I have a left axis, if I look over at the precordials and I see an S wave in V6, bam, you just diagnosed your patient with a left anterior fascicular block. So I want you to take a look at this one. This is where, a lot of people, again, they don't want to commit this to memory. This is where this saves a human life. So a little backstory on this patient. This patient called for syncope and presented to the crew tachycardic, as you can see there, with orthostatic syncope or near syncope type symptoms. And so I think most of us, we see tachycardia, we see, it's sinus in nature, so we have sinus tachycardia. And if you're not trained to look at this stuff, you might go, sinus tachycardia, looks like maybe I have a right bundle branch block there if I use the old blinker method. By the way, I also hate that, so don't do the blinker method either. The blinker method actually isn't 100% right, so it'll lead you astray. And again, we can do better than the blinker method. So when I'm looking at this, I have an orthostatic syncope patient with tachycardia with, I don't see STEMI, I don't see any major things, so whatever. This is probably just dehydration, right? And so I think a lot of people would go, I'm going to just give this patient a large fluid bolus. But the crew saw something here that I think matters. It clearly matters because it made a huge difference in the care of the patient. So they noticed that V1's QRS is up. Now remember, what is V1 supposed to be? V1 is supposed to be completely negative, and then V6 is positive, and everything is supposed to progress through there. And so that is not the case. So that tells me that V1's up, and V1 is up because something is happening with the right ventricle. Now, this could be a right bundle branch block. It's not quite a true right bundle, but it could be. But what it's telling me is when I see this EKG, it's telling me that I have right ventricular changes because I have an upright in V1. Now, I have a whole episode on some of the other things on this ECG, and I don't want to kind of tip it off just yet, but there's also some other abnormalities. Your T waves are down. They are all pointed down in V1, V2, V3, and lead 3. That's really ominous. V6 is negative. You have an S wave. That's not good when you have these other things. And then you also have This one's a little less sensitive, although the textbooks love this one more, but you have an S wave in lead 1, a Q wave in lead 3, and a T wave inversion in lead 3, which is called a S1 Q3 T3 pattern. And so this prompted the crew to pause and to do an ultrasound of the patient. All right, so I have a lot going on the screen here, but to the far left, we have a parasternal short axis ultrasound that I flipped upside down. The reason I did that is so that it would orient anatomically with my picture that I have in the middle, so you could kind of see the ECG map there. So now you'll notice it's a little bit different. The right ventricle on ultrasound from this viewpoint should look like a croissant or a crescent shape. They like food analogies with ultrasound, so they say that the right ventricle looks like a croissant and the left ventricle is supposed to look like a donut. And so you can see the left ventricle is definitely holding its shape. It's squeezing away, really, really compressing, and that's because it's not getting any blood. And it's not getting any blood because you can look at that right ventricle, and instead of looking like a croissant, it's really, really big. And it's really big because it's full of blood. And it's full of blood because it's trying to pump against a massive pulmonary embolism, and it can't. And it's actually squishing on the left ventricle and causing diastolic heart failure. Now, what's fascinating here is because the right ventricle is straining so hard, it's producing extra energy. And that energy is going to show up in the leads that look closest at the right ventricle, which is what I have labeled there. So your leads on a standard 12 lead that look at this part of the heart are V1, V2, and V3. And so one of the first things that happens when it bows out like that, when it dilates, is your T waves flip. And that's one of the most specific findings for pulmonary embolism. In fact, it's far more specific and sensitive than S1Q3 T3 as an EKG diagnostic to identify pulmonary embolism. Now, of course, I'm a huge advocate of ultrasound, and ultrasound's an even easier thing because you can just look at that and you can see that giant right ventricle. You can see it squishing on the left ventricle, and you've already made your diagnosis there that you have RV strain. And in the case of acute RV strain, your number one diagnosis is going to be PE. Now, why does this matter? Well, because remember, we thought it might be orthostatic hypotension secondary to dehydration, and a large fluid bolus is typically what we would give. Well, what ventricle is that fluid going to dump in? It's going to dump into that right ventricle, which is already engorged, which is already failing, and it's just going to further exacerbate the RV strain. And the other key thing to remember with PE, and again, I have a whole video on it, so I won't go too in depth, but is positive pressure ventilation can also be detrimental in patients who have acute pulmonary embolism with right ventricular failure. And so a lot of the standard resuscitative therapies that we provide to shocky tachycardic patients can be very detrimental to a PE patient. So again, this is where knowing what V1 is supposed to look like literally saved a person's life, because the crew recognized this, they did the ultrasound, they confirmed the diagnosis, and then they treated the patient appropriately and got him to a facility capable of performing thrombectomy on the patient. They made a full recovery. So it was a good catch on the crew, and they saved a human life. All right, so another example here. So in this case, the patient presents with chest pain, hypotension, bradycardia. We get our EKG, and hopefully your eyes kind of, there's a lot going on here. Your heart rate is slow. We see your P waves are not regular. Your PR interval is changing. Most likely have a complete heart block. We see some ectopic complexes that are wide and don't have any P waves. So we see so those are PVCs. But the thing I wanted to focus on here was, again, where the ECG map can help correlate. And this is actually why I don't teach ICL leads when I teach my medic students about, or when I lecture any about acute MI recognition, because again, I hate it because it is robbing the student of understanding what they're doing. We want them to know what they're looking at. If you're looking at V1 and V2 and trying to think, I stand, oh wait, eyes over there, it doesn't, well, A, it's silly, and B, there are just way more effective ways. And I've had students who memorize it who can tell me, oh, well, V1, V2 is the S, so that's septal, but they don't understand what that even means, or what septum is, or where that is in the heart, or how that correlates with the anterior, lateral, or the vessels, or anything. And so and this is a beautiful example of this, because this patient is having chest pain, and then we see S, there is no clinically significant ST elevation anywhere on here. And so if you're classically trained, you just go, oh, well, it's not a STEMI. But when I look closely at this, there's some problems. I see ST depression very predominantly in V2. Now this case is actually fascinating for a couple reasons, because that PVC in V2 also has ST depression that's moving with the QRS, which actually fits this whole thing called Scarposa criteria, which I did another video about, but not to nerd out on that. Let's look at the normal complexes there, and I see ST depression in V2 and V3. Well, if you know where those leads look, then that can have some pretty significant clinical implications. So I've mapped this out here for you. V2 and V3 look at the front of the heart, so I have ST depression in the front, which makes me very concerned for the potential of a posterior STEMI, which the crew also were worried about. And so they did what anybody should do anytime you have ST depression in any of your anterior leads, which is V1, V2, V3, or V4. And they took off V4, V5, V6, and they put them on the back. They shifted V1 and V3 to the right, and they did an 18 lead. The right side was negative or unremarkable, but the back side showed what you see on the screen there. And you can see that, especially in V5, we have some positive ST elevation confirming the diagnosis of posterior STEMI, which was confirmed on cath. And the patient did make a full recovery on that, so that was a good catch by that crew as well. So again, kind of final thoughts here, just to review on the fundamentals. How big a waveform is, that tells me total energy received. Little waveform, little energy, big waveform, big energy. Width is time. The wider it is, the longer it takes. And then up versus down, that tells me where the direction is flowing. And the only way to know that is to memorize that map. If it's up in a lead, that means it's moving towards that lead. So if my QRS complex is up in AVL, well, that means that the depolarization wave was moving towards AVL. If it's up in 3, then it was moving towards 3. And so that can tell me all kinds of things. And that is also applicable when we're talking about things like ST elevation, ST depression, and many, many other things. All right, thanks, guys.